Hello, this is my talk for World Delirium Awareness Day 2022. I'd like to talk about what I learned from my care experience um, of a loved one with delirium. A bit of a difference, though. I'm a cognitive neuroscientist by training, and I wanted to match up the neuroscience with what I experienced as a carer, something called phenomenology, which I think is very much underappreciated in delirium. It means you don't go into it armed with preconceptions about what delirium is or should be. It's what you experience that counts. So, my loved one, uh, this is very sad. A few years ago, she was admitted with a chest infection, and after that, she's experienced long-term cognitive decline, now totally dependent. Uh, a number of delirium episodes present during after the admissions, never mentioned or any of the ward rounds, never mentioned even in the discharge summary. A real travesty in a London teaching hospital from consultants and registrars. No explanation about delirium at all. In fact, the whole episode was really bad. Now, going to the DSM-5 criteria for delirium, uh, currently defined as follows: disturbance in attention, unawareness, acting over a short period of time, a cognitive, for example, dementia was there for months or years, and a rapid fluctuation during the course of the day. And it could be additional disturbance in cognition, memory, disorientation, language, visual-spatial ability, perception, not better explained by a pre-existing neurocognitive disorder. And 5, evidence from history exam lab findings. And there you go. So it doesn't mention consciousness, it doesn't mention speech disorder. It doesn't really go much about the main symptom for me, which was a fluctuation in consciousness or the complete obliteration of self knowledge about you, who I am, my name, who I have come from, nothing. And this is a really wet, pathetic list of criteria. So I have two personal concerns. What are the symptoms of delirium? Well, of course, it's based on my experience, but why am I not alone? And what is driving the neurodegeneration that some individuals happen to have after delirium? Now, uh, in fact, it's by no means that is proven to me there's a thought disorder or disorganized thought in delirium. For example, it could simply be a speech output problem. Not all speech aphasia is speech receptive aphasia or um, output expressive dysphasia. This is really a really medical student understanding of aphasia, really not good enough. It could be something far more sophisticated. It could be neologistic jargon aphasia, where you're talking gibberish. Anyway, the output could be gibberish, but what's going on inside could be okay. We don't know. But anyway, this is work unresolved even after decades of people looking at it. And was it a stressing? Of course it was. To me, nobody could tell me where it came from, what the mechanism was, how long it's going to last for. Everything about it is just stressing. And when you have clinicians who don't even want to mention it by name, it's doubly awful. So, anyway, what is the experience? I'm not talking about what are the symptoms. I'm talking about what are the experience of people who experience delirium or the chaos. Now, this was a very interesting paper, but talks about a dream-like state, not in fact alone. There's many accounts which are like dreams, waking up from a dream, not hallucination or delusion as such, just a dream-like state. So that's something which is simply not captured in DSM. Why is that important? Because we're talking about delirium being the prototypical disorder of consciousness, somebody flitting in and out of a sleepy-like state. It looks awful. That in itself is distressing. And it simply does not obey traditional neuropsychology. We don't have cognitive domains which are readily intact in delirium. So to talk about attention being abnormal, fine, but perceptions are normal, memories are normal, language is abnormal, speech is abnormal. So actually, give us a break. You want to be able to find a double dissociation where you have unimpaired, impaired function following lesions. You don't get that in delirium. So anyway, the idea that the brain is organized in terms of modules is not applicable to delirium. And therefore, this modern phonology, we can take hit this with a hammer and all the cognitive domains will be affected, as will be behavior. So anyway, Rose is right. Looking at some symptoms maybe is understandable if you look at the meaning behind these symptoms. And actually, once you start to do that, you find a rather different understanding of delirium. So here is, for example, a really good paper which I was reminded of recently because I happened to be reading about this. Like this, delusions and hallucinations are on the spectrum of the dream-like state. In fact, there are loads of theories about delusions come from things like, is it an extreme form of dream, or is it some predictive coding problem or something? We just don't know what's happening in delirium because nobody is doing it. And the number one candidate for this is the default mode network, of course. Why? Because that is the network that represents self, who you are, what you have come from, your memory about yourself, your interaction with other people. The default mode network is the big network in the brain. So I'm not talking about models, I'm talking about networks in the brain. And there are loads of them. Obviously, other candidates are the dorsal attention network, and obviously the clues in the word attention, because attention is abnormal in delirium. We know that, I know that, you know that, everyone knows that. And the salience network is abnormal in delirium. You just have to look at somebody, my loved one, with delirium, and you know that she had very abnormal behavior towards things in the environment. But what does it all mean? It's possible to tie it up in the neuroscience. A definition of consciousness is this flitting in between the default mode network and the dorsal attention network. So they co-vary, and this flitting of the states is a disorder of consciousness, which is exactly what we think delirium is. So single case method really is not appropriate here. And in fact, it's really important to appreciate this. Nor as such as big data unless you have a theoretical underpinning and a very good idea of what the symptoms are. I've already explained that the delusions and hallucinations could be, in fact, a dream. I've explained that what you call disorganized thinking could be my disorder of speech. Anyway, Ken Rockwood is miles ahead and has been for some time. So look at this. He describes delirium as something which has happened and can produce a cognitive impairment. Is it vascular? Ken, as I understand, believes it could be vascular. Look at Sarah Pendlebury's elegant work on vascular changes and delirium. It could also be non-vascular. In other words, you could have IL-1 and IL-8 felt in delirium being pro-inflammatory states, accelerating a neurodegenerative state. Not impossible. And that's actually what you get, as we know from Professor Andrews' work many years ago with Suzanne Frieda and Ken Rockwood in complete recovery. And this last year, I itemized, because nobody else could be bothered to do it, all the neurological questions about what causes the long-term cognitive impairment and how do we treat it, or even more importantly, how do we not treat it? We know about neuroleptic sensitivity in dementia loop prototype. How do we know, for example, that delirium is not simply the first presenting symptom of dementia, for example? How do we know it's not a synucleinopathy, and therefore you shouldn't go in with neuroleptic? We don't know, because the state of post-mortem evidence is infantile. So here's one paper I referred to. Two personal questions that I'm left with, embarrassingly, in WDAD 2022 are: what are the symptoms of delirium, and what is driving the neurodegeneration in individuals following delirium? So actually, this is really a pitiful state of affairs. I understand DSM's being revised to 5 text edit or reduction of, I don't know what it is, 5 TR. And I don't think we're going to get much of a theoretical leap in that, and judging from past experience of DSM, which is why I suggest we convene a new special interest group to look at the neural basis of delirium. So we bring together everyone from all the specialties and bring together carers, patients, phenomenologists to actually look at what the symptoms are and what the neural basis actually is. And that's my talk, uninvited, for this year.